Bonjour, bonjour à tous. Je m'appelle Marie-Louise Vachon et je suis microbiologiste infectiologue ici au CHU de Québec. Avec mon collègue Sébastien Poulain, nous étions responsables du pilier clinique de CAHR cette année. Et comme vous le voyez, je suis seule ce matin devant vous. Alors, malheureusement, le père de Sébastien est décédé cette semaine, donc il est présentement avec sa famille. Donc, on lui souhaite nos plus sincères condoléances. Hi, everyone. I'm Marie-Louise Vachon, ID physician here in Quebec City. And with my colleague Sébastien Poulain, we were responsible for the clinical pillar of CAHR this year. I am alone this morning because Sébastien's father, unfortunately, passed away this week. So he stayed with his family, and we send our deepest condolences. On a happier note, we are honored to welcome this morning from Montreal, Dr. Jean-Pierre Routy, who is our invited clinical science plenary speaker for CAHR 2023. Dr. Routy is a tenured full professor in the Department of Medicine at McGill University. He received his medical degree and completed his residency in hematology and oncology at Université d'Aix-Marseille in France in 1986. In 1980, he was one of the first recipients of a CTN postdoctoral fellowship. He is an attending physician in the Division of Hematology and at the Royal Victoria Hospital in Montreal. He is also the clinical director of the Chronic Viral Illness Service and the director of Réseau Sida et Maladies Infectieuses FRQS. Dr. Routy was the co-chair for the 24th International AIDS Conference that was held in Montreal in July 2022. His research efforts have proven internationally important in areas such as T-cell and dendritic cells in HIV pathogenesis. He has authored and co-authored more than 420 peer-reviewed publications in high-impact journals such as the New England Journal of Medicine, The Lancet, Nature Medicine, and Blood. Today, Dr. Routy will discuss CMV latent infection in HIV, how it contributes to immune activation, its influence on the HIV reservoir, and the potential effect of anti-CMV vaccine and antivirals on HIV inflammation. Dr. Routy, merci encore d'avoir accepté notre invitation. C'est un honneur de vous recevoir à Québec. On vous écoute.
Merci beaucoup Marie-Louise d'être ici à Québec devant vous et de parler un petit peu d'un sujet moins connu ou qu'on oublie un petit peu, le cytomegalovirus. So I'm very pleased to be here and to discuss about what do we do in 2023 about CMV virus. So that's the conflict of interest and learning objective, at least to learn something. So, cytomegalovirus, as you know, means a big virus, and it was diagnosed in 1861 in the lungs, maybe a parasite at that time, and looking like OL eyes appearance, and that was a microscopic observation. And then we had to wait 1956 to discover it was a virus and were able to be grown. And the one at Harvard who discovered or been the leader is Thomas Weller. So that's a virus. And what he's doing, and the focus will be, of course, on immune change, not on virological factors. As you know, CMV acquisition is mainly from oral, from respiratory route, and go into your lungs, throat, go in a bone marrow where it will establish latency, and you get this virus forever. And then you can still express some of them, and you may transmit the virus by salivary gland, and pathologically, that's where it was initially diagnosed in human in a parotid gland. And interestingly, there is a new way of transmission identified by Dr. Isabelle Bouquaran from Montreal Saint-Justine Hospital, daycare and not hospital can be a place where a mother being CMV neg can be infected by young kids or baby and then become CMV positive. And she called it the ping-pong effect because we always think about the mother-to-child transmission or vertical transmission by placenta, blood, or breastfeeding. Also, you can get in a daycare system. So it's very important to remind that you may acquire, and of course, if you are a CMV neg pregnant woman, you should avoid exposure to CMV. So we are in Canada, as you know, and we are in Quebec. And I look worldwide, what is the seroprevalence on the planet? And you can see 2 countries who have the least CMV infection, Ireland and Canada. And if we stay here in Quebec City, on ladies, mean age 27, during pregnancy, you have only 23% of young ladies in Quebec to be CMV positive. So in a way, it's good. We're less infected. Probably there is a temperature effect. And also, it allows us to study CMV because we can compare relatively large CMV negative population. If you go to Benin or China, everyone in CMV pos, so it's hard to have comparative studies. So CMV, it's one of its kind as it shares some HIV-like activity. It's a chronic viral infection, so there is some damage to be replicating or to have a low presence of antigenic lifelong, so that may do damage. And the CMV has the intelligence to not kill the cell, but to maintain the life of the cell it infects. So that's a good strategy. And there is 2 ways to escape immune system. So MHC class 1, so that for CD8, and also HLA-E for natural killer, and is able to change the cell and to escape and maintain presence lifelong. CMV can be reactivated from latency, mainly in AIDS patients, everyone knows, and then you can have the classical CMV damage in your gut, lungs, eyes. CMV retinitis was so terrible at the dark age of HIV. But that's the past, what we hope is the past. We focus now on people doing well. There is also occasional reactivation, people having COVID, having bacteremia, ICU, but also even us, because probably 60% of you are CMV. There is probably some blips or some in tissue, may not be reached or measured in the blood, but there is probably some very small reactivation, but on 15 years, that may have an impact. Importantly, elderly people have damage, in a way, immune system, and some cohorts have shown a decreased life expectancy on a very large cohort, showing that people being CMV may lose 2 or 3 years of life expectancy. We know what is very characteristic, that CMV expands, doesn't kill CD4, it expands CD8 in a terrible manner or unparalleled manner. 10% of your blood T cell are just devoted to fight CMV all the time. So it's a huge part of your repertoire focus on just CMV. And that may bias the way you will respond to vaccine and to an infectious disease. And we know now that T cells, mainly CD8, are more differentiated and they look like older CD8 T cells. You can see that like HIV, like yesterday for B cell with Suzanne Moore, there is a change over time when the antigenemia, when a virus is present and not cured or not clear. So the T cell also, the CD8, mainly for CMV, they are different, they are biased. And of course, as the antigenic stimulation persists, you cannot have the best memory, the antigen-independent memory, like HIV doesn't exist because the microbe remain at a low level or latent and may reactivate. That's for the CD8. If we look at the natural killer, it's a more recent work, and many things are common between natural killer and CD8, with the interleukin 15 being the growth factor for these two types of cells who look like a bit the same. There is a new discovery that natural killers are considered to be innate immune cell. Now there is in between natural killer. They may be adaptive natural killers. They may change. And some receptors highly studied by Nicole Bernard at McGill using aging cohort or primary HIV cohort from Quebec and Canada was able to show also a bias of CMV positive expression certain receptor. And for NK, the number of receptors is extremely difficult to follow, and you need to be a CMV immune specialist. So, but there is a bias in the way. Something can be good, nothing is always bad. So there is some ADCC, the antibody-dependent cytotoxicity, may be enhanced and maybe in a middle-aged individual, more than elderly subject. So sometimes it may be good, or the NK, as it stimulates your CD8 and natural killer, can be a booster for something else. So CMV is not always bad, like everything in life. So latent CMV infection. So why there is such an interest? Because even if you are CMV, within the CMV person, if your IgG level, your titer is very low, no much fight, no much consequence. However, if you have a very high, just the antibody means there is a fight being more strong, you have damage due to chronic inflammation, mainly touching the vascular system in your body, and then you have more damage, more inflammation, and some studies show earlier mortality. So it's not just CMV, it's also the ability of the host to control the low level of antibody. When it's high because you don't cure it, you are more inflamed because you fight not perfectly, and long-term effort, as we know, is damaging. So we look at McGill and Dr. Tsoukas, look at people who come to the hospital for annual follow-up in a geriatry or general medicine center in a hospital. And he selects from 520 followers, every year, people who look healthy with no cancer, no big disease, just a good 70s. Of not, Dr. Tsoukas is in 70s, so you can accuse him that he just wants to do science to improve his own life because he focuses people having his age, so that's maybe a source of motivation. You can see that CD8 total lymphocytes are more elevated in healthy sedentarians. Okay, because we know it's more CD8. So looking at the ratio, even outside HIV, the CD4-CD8 ratio is a cheap marker of aging and is used in a global medicine or even health. Now we call it health. And the ratio was much lower in healthy, non-HIV, CMV positive individual. And he found, about 70% at this age were CMV positive, and 1/3 was CMV negative. If you look at CD4, conversely to HIV, no effect. So it's like a pure CD8 expansion stimulation. And you look at the absolute CD8, you can see generally is 400, and CMV positive healthy 10 years, they have double 800 CD8. And you know, in HIV, lower the ratio, more you prone to a non-inflammatory AIDS event, mainly cardiovascular and neurocognition. So that may contribute on top of natural aging and HIV, the CMV add-on. Dr. Tsoukas even went deeper. He looked at a marker of fitness. So when your cells are very fit, they express the marker CD28. So it's a good marker. And of course, if you look at CMV CD28 negative, it's bad. And you can see that the LC have CMV pos have much more bad CD8 because they CD28 neg. Then he went deeper at DNA methylation. You know, when a gene is methylated, I mean it's a sleeping gene, like for the X chromosome, one of two is sleeping. So he's methylated, he's doing nothing, just relax. And you can have an epigenetic clock by looking at the change. And you can see in a more brown color that people being CMV have at a gene level or epigenetic level, so post-translational level, more aging and more time spent damaging. On top of that, it finds that people having methylation have more glycolysis. You know, the Warburg effect, if you work too much, you eat too much sugar, is bad. For cancer, it's bad for immunity now since 10 years. And even in this cohort, they find that the cells are more prone to glycolytic effect and less to phosphorylate oxidation. So it's a very strong paper and well done, and we are very pleased from this magnificent work. So that's outside HIV. You can say it's a COVID epidemic, we need to know about COVID. So some study, and a relatively very nice one in Philadelphia, in GID, show on a cohort of 246 participants that just HIV, COVID acquisition is more prone to infect a CMV positive person and independent of the age and the ethnicity. Now, if you go to the hospital, you may be more sick and spend more time if you are CMV prevalent. Conversely, nothing is bad, nothing is one color. At Paluso, at CROI 2023, show that for the long COVID, if you're CMV positive, you have less neurocognition. So it seems to be protective from long COVID, but to be bad with acute COVID, which is always difficult to understand, but data are high quality and played in this favor. So nothing is always one tone. So let's go to HIV. So in February 1983, one editorial from New York Times report, because it was unknown disease, that maybe CMV or CMV variant and maybe EBV were the causal agent for the new AIDS epidemics, and that was supported that AIDS patients had much more seroprevalence on CMV than non-AIDS patient. That was the past, but sadly, even in China, with some modern technology doesn't always translate to daily care of patients. From 2017 to 2021, in a hospital I visit and I was invited to give advice, but you know, if you have no medication, no advice. And they show that the viremia by PCR, so it's different here, but still is a predictor of death. And they use ganciclovir, and patient didn't benefit because it's so neutropenic drug, and also it takes at least 5-6 weeks to improve the patient, and they were dying. People were below 50 CD4 cells, but they show that PCR, it's an independent marker because it didn't exist PCR at the time of bad AIDS, but still it's sad to see that people can arrive in a hospital so late. So you all know that there is a root of inflammation. That's a very well-known cartoon from Justice and Peter Hunt. HIV on its own, and even discussed 2 days ago, even if there is no replication, there is still a release of HIV protein, or so there is still activity, and is proven now to induce immune activation on its own, so it's HIV on its own. CMV, we will see, and certainly yes, and also the famous leaky gut or translocation. So let's see what we can distinguish these 3 factors, or maybe they linked. So if we add HIV on top of CMV, of course, it's a double dose. You have a default in CD4 that also is a coordinator of the CD8 cell. So then if you have CMV, your CMV fight may be slightly damaged or extremely damaged if your cells are below 100, and then CMV can become lytic and destroy your tissue. But of course, we add on 2 bad things in the same host, and as the good news is when CD4 go up to 200, at least the CD4 help the CD8 functional response. So we look in elite controllers, so the natural evolution of a few people who don't need medication for at least a decade. And with Stéphane Isnard, we look at the CMV title, so the level of antibody against CMV, and the slope, the decay of CD4 cells with the Cécile Tremblay cohort and Nicole Bernard Canadian elite controller cohort, so thanks to this cohort. And we find that was a link. And then people or reviewers said, yeah, CMV, maybe it's every herpes virus. So we did EBV, and there is no link with EBV. Good. So CMV, we look at the translocation marker LPS, and found that more you have antibody, more you have gut damage or a marker of part of a bacterial microbe circulating at low level in your blood, and that was totally not seen for EBV. So there is something in the natural evolution of HIV, including the super elite controller. So then in Italy, they look at the effect of different class of drug on CD4 recovery and find that ENSTI may have a better CD4 than NNRTI and protease inhibitor. But they were able to have a relatively large cohort and to find CMV neg, because it's rare and much rarer in HIV than general population. And they find that the recovery was superior for people not being co-infected with CMV. So even CMV is an important contributor for improvement of CD4-CD8 ratio, even now. So, because we find a link in elite controller, we did a larger cohort with Rayun Ramanda when he was at McGill. And each group, so HIV untreated, CMV pose, more gut marker damage, the IFA marker, even treated didn't go down and seems to be still persistent gut damage. And even in healthy, non-infected individual, there is a link with gut damage and microbial translocation. And when we look at the LPS, so the consequence of the leaky gut, we confirm that more leaky gut by bacterial marker being in CMV pose, treated or not for HIV, and even in healthy control. So there is a link between CMV and leaky gut and adding on HIV direct stimulation. So we did a review on a vaccine and tried to capture all the things we read. But interestingly, and not shown on this slide, majority of response is damage if you are co-infected with CMV. But if you are in your 30, 40 years of age, CMV can even improve vaccine response. So it's a bit complex, as there is maybe this ADCC improvement. So in certain time of your life, you may benefit, but on long term, no hesitation, is damaging. It's an aging effect. But in mid-age, it may be a way to prepare your body to fight or to respond to commercialized vaccine. So the good news, there is new medication, because ganciclovir is nice, or foscarnet when you have a tissue damage, but there is a cost, neutropenia or nephrotoxicity. But a new drug like letermovir and marbavir are available in certain conditions in Canada. So pas de deux, in a sense, what can be the crosstalk, and if we treat, what should be improving maybe the two partners, or the two CMV and HIV. So we want to, if we have new medication, can we tease out what is the inflammation driven by HIV, driven by CMV, and we know that latent infection is associated with cardiovascular disease, gastro, translocation. And can we reduce the gut damage? Because we all agree that in overweight people, that's a second attack or level of inflammation, so it's bad. But if we can improve patients, not all their life, but 1, 2, or 3 months, and then they may be a better recipient to have eradication or vaccine therapy to block, you repair a bit, and then you intervene. As we did for HIV, you treat them before trying to give an additional therapy to go further. So maybe we have to think the way to treat HIV, then CMV, and then to do something when the tide is even and not under a big damage or change. So, as you know, Peter Hunt was a plenary speaker 6 years ago in Montreal for CAHR, and in 2011 he shows that ganciclovir was in fact the only study randomized showing de-inflammation measured by CRP level and activated CD8 T cell, cheap and easy marker, and it was limited, and that's why the study was stopped due to neutropenia and toxicity of ganciclovir. But the concept that blocking CMV can contribute to decrease at least the CMV-related inflammation and what we show gut damage. And some people look at CMV in a gut tissue in vitro and show that letermovir can also do the same trick by decreasing CMV-induced tight junction disruption, so it's an improvement, if you give letermovir at least in vitro model. So then we decide why not doing that with the support of Merck, who is commercialized this drug in Canada, to try to treat for a while, so 14 weeks, because that's the time for transplant prevention for CMV, that's the dose used in human and accepted by Health Canada, to see if we can see a change in inflammation in gut, in HIV reservoir. Some studies say CMV co-infection increase reservoir, others show no difference. So it's still under debate, but can we improve? And if we improve, then it will be the optimal time to do something else, to go to cure or functional control. So letermovir, it's a DNA terminase inhibitor targeting a subunit of a viral terminal complex. So it's approved in Canada for CMV prophylaxis for 14 weeks after allogenic hematopoietic stem cell, and the drug is highly expensive. And there is a very good profile outside the economical cost. 2 pills of 240 milligrams, or 1 pill or 480 milligrams once a day for 14 weeks with no neutropenia and relatively well-tolerated medication for very sick patient or transplant patient. So there is inclusion and exclusion criteria, and Lena, who was a postdoc in her lab and herpes specialist, got also at EAS this summer in Montreal a prize for another herpes virus, the Kaposi sarcoma, and that's the criteria for study participation. So that's the study, the CHOW study, so CMV inhibition associated outcome study. We try to find some acronym. And there is a gut biopsy for people who want, before and at the end of letermovir, to see if we can repair the gut, and blood marker of inflammation, microbial translocation. So, as we say that Canada has a very low prevalence compared to other countries, maybe the screening for CMV ladies or potentially pregnant women is not optimal. And there was some lay press communication of a father having his son being deaf, having neurological damage to acute CMV during pregnancy of his spouse. And there is a new pressure. And once again, Dr. Boukwaran from Saint-Justine is also pushing and having guidelines to screen several infections during pregnancy, including CMV in Canada, because you may have a toxic effect for the baby. So based on that, Moderna company have a new vaccine using RNA technologies. That's why it's called Moderna, ARN, Moderna. Well, nice name. And Dr. Don Vim at McGill is leading our group for a very nice name, CMV Victory, like HMS Victory, the Nelson boat, Trafalgar battle. And so we vaccinate healthy lady between 16 to 40 3 times in hope that antibody will prevent acute CMV infection during future planned pregnancy. So that's also very interesting that with a platform, a new technology, we can do much better than before, and at least is well tolerated for now, and the study is ongoing. So also, nothing is bad, nothing is always good. Louis Pitcher on the west coast of US developed, a vector with CMV to try to push the immune response and to develop an HIV vaccine based on CMV. So it can be enemy, it can be friend. It's always a dynamic relationship. And at least in a SIV model, he can elicit immunological control using his technology with CMV vector. So it's also a pas de deux, but in a good direction. So for conclusion, Canada is one of the lowest seroprevalence for CMV, which is maybe bad because the screening for pregnant women is still low and should be increased. And we are very pleased to have a CAHR member being extremely active in this strategy to increase. Also, some critics said, well, many studies are cross-sectional, and as we know, CMV serology increase with age, increase with low social economic determinants and country of origin. You may select people who do poorly in any trial, in any condition, just because this CMV, a reflection of other lifelong comorbid determinants. So it's very important to have a large cohort and to have multivariate analysis to prove it's CMV on its own and not just a cofactor associated with CMV acquisition. So CMV latent infection definitively shape immune response that contribute to inflammaging and non-AIDS morbidities in what's 10%, 50%, 80%, we don't know. And we hope with our study to at least determine what is the proportion. And remember the work of Dr. Tsoukas in non-HIV 70s people. They have a quite important inflammation, so we will know hopefully. So there is new CMV medication, much less toxic, so we need to visit this issue in HIV, but also in other conditions. It's nice to see there is a CMV vaccine, several, including Moderna and at least one in our institution. And also CMV can be a vector for vaccine development, including for HIV. So thank you for all the people who contribute, and the new logo from Réseau MICE, maladies infectieuses chroniques et émergentes. To thanks also Guy Boivin, who was very helpful, a specialist of herpes virus, leader, and so we follow his advice with Marie-Louise Vachon, and we want to expand our center to 4 centers in Canada, but we have some low difficulty to get the medication, and COVID effects, so we hope to be fully starting soon. And people from McGill, from the CHUM, and Mario Legault for coordination, and CAHR and CAHR, and most importantly, participants. So thank you very much. Ah, le plus important. Merci beaucoup.
Thank you. This was wonderful, magnifique. On a du temps. We have time for questions.
Ah, il y a quelqu'un, un local qui veut parler. J'espère que c'est des questions et pas lui qui va dire qu'il a quelque chose. Alors, c'est des questions ou des commentaires?
Question. Poulet de l'œuf. CMV associé avec un état progressif. Qu'en est-il tu dis diminution des CD4, mais fonction de CD4? Est-ce que finalement c'est un défaut des CD4 qui fait qu'il y a une réactivation? Ou bien inversement, c'est le CMV qui drive une déplétion supplémentaire?
Non, il semble que ce soit vraiment le CD8 d'abord, il y a besoin d'en avoir beaucoup pour contrôler, et les CD4, dans toutes les études, il n'y a pas de différence, ou il y a très peu d'atteintes, c'est vraiment CD8, et c'est vrai que c'est un peu étonnant que ce soit natural killer, qui sont biaisés, CD8, et les CD4 semblent échapper ou ne pas être trop abîmés, au moins dans les études, des grandes études, et pas des modèles in vitro ou animaux.
Pourtant, dans ton papier, tu montres bien que c'est associé à la vitesse de déplétion des CD4.
Oui, alors c'est tout Nicole Bernard est ici, elle a même publié un papier en disant que l'inflammation n'influençait pas sur la dynamique de la perte des CD4, donc c'est très difficile de répondre, l'observation et ton commentaire est pertinent. Maintenant, le mécanisme, pourquoi? Alors peut-être c'est l'inflammation générale, parce qu'il y a plus d'IL6, je ne vais pas détailler, mais il y a plus de cytokines. Donc peut-être que ces cytokines, qui sont aussi élevées dans le vieillissement naturel, contribuent à l'altération globale et principalement des CD4 chez les élites, et le mécanisme est probablement indirect par le biais de cytokines.
Uniquement cytokines.
C'est ce qu'on pense. Enfin, maintenant, il n'y a pas de truc direct. Anyway, alors merci beaucoup, et c'est un plaisir d'être ici avec vous durant ce CAHR sans masque et en personne.